Welcome to the next installment of our Think Big series brought to you by PSG. My name is Janine Johannes and I am the head of Group Human Resources at PSG. Did you know that PSG is a leading financial services group with an extensive footprint in South Africa and a presence in Namibia? We've been in operation since 1998 and offer a value-oriented approach to our clients' financial needs by offering our clients access to a wide range of insurance and investment products based on comprehensive advice. Our clients benefit and has access to proprietary products and solutions, as well as a comprehensive list of third-party products. In today's installment of the Think Big series, we tackle an issue that dominates the world headlines and is on everybody's mind: COVID-19 vaccinations. Should I get vaccinated? What vaccine should I get? Do I have a choice? When and how does government plan to roll out vaccinations to the people of South Africa? Hopefully, you will get some insightful answers in today's session. The session is hosted by award-winning financial journalist Bruce Whitfield, who needs no further introduction. And he will be talking to Professor Shabir Madhi. Professor Madhi is a world-renowned expert on vaccinology and has been sharing his views on COVID-19 pandemic and the future of pandemics. He is a professor of vaccinology at Wits University and currently holds the position of director of the Medical Research Council Respiratory and Meningeal Pathogens Research Unit. An A-rated scientist and trained pediatrician, he chairs the National Advisory Group of Immunization in South Africa and was formerly president of the World Society of Infectious Diseases. He is also the immediate and past director of South Africa's National Institute of Communicable Diseases. And against this backdrop of his exceptional, impressive experience and qualification, I think we are in good hands today. The topic aptly titled, The Future of Vaccinations, will provide you with some thought-provoking insight in our pursuit of so-called herd immunity and what role our current experiences will have on our approach to future pandemics. Also note, our social media campaign is #ThinkBigPSG. The series is free, shareable, and anyone interested, whether you're a PSG client or not. Let's hand over to Bruce.
Janine, thank you very much. Prof. Shabir Madhi, who is one of South Africa's leading vaccinologists at Wits University. It's hard to believe that 12 months ago, we thought we'd probably all be dead by now. There was a huge amount of fear and trepidation across not only South Africa, but the world as well. And I know that we've had very high death rates, but perhaps this pandemic hasn't been nearly as terrifying as certainly the Spanish flu of 1918 to 1920.
Yeah, so certainly I don't think that it would be possible to make any sort of head-to-head comparisons between the pandemic that we're experiencing currently and what occurred in 1918. Obviously, these are two very different viruses. And in fact, the society as we know it is very different. The living conditions, the access to healthcare is very different compared to what it was in 1918. But that being said, in 1918, there were close on to 50 to 100 million people that probably succumbed from the Spanish flu, which is way above what we have experienced with COVID-19. But that's not to say that COVID-19 hasn't had a major impact in terms of mortality, including in a country such as South Africa. For all intents and purposes, the current estimates with regard to the number of people that have succumbed from COVID-19 is a significant underestimate, and more so in low and middle income countries, where we've never been able to scale up our testing capacity to fully quantify the magnitude of both hospitalization, severe illness, as well as deaths from COVID-19, including in a country such as South Africa.
I mean, and we look at what they call excessive deaths. It's a dreadful term, but it's any deaths above an average, and every country measures its annual death rates, and it gets a very quick idea as to whether or not there are more or fewer people dying each and every single year. This year, there seemed to be a large number of excess deaths. In fact, the death rate seems to be 3 times higher than average. It does imply then that our COVID death rate is possibly considerably higher than the official stats suggest.
Absolutely. And I think the importance of this modeling that looks at excess mortality is just how synchronous it is in relation to actually reported COVID-19 deaths. So the trajectory of the COVID reported deaths and this excess mortality is almost identical. And as you correctly point out, the excess mortality estimates indicates that close on to 150,000 people have probably died of COVID-19 in South Africa, as opposed to the 50,000 that have been reported. Even if we assume that only 70% of that excess mortality, in fact, is due to COVID, which would be really a conservative estimate, where South Africa ranks is at number 11 globally in terms of the highest mortality rates. Our mortality rate then comes in close to 190 per 100,000 of the population, which in fact is higher than Spain, Italy, United Kingdom, and even the United States. So South Africa hasn't been spared for all intents and purposes when it comes to death from COVID-19, despite the huge amount of restrictions that has been placed on society. And it speaks to the issue in terms of the effectiveness of many of these restrictions, in terms of reducing infections, as well as in terms of preventing deaths.
I want to talk about the restrictions in just a moment because it's a massively contentious issue. But when we look at our death rate, and we say 190 per 100,000, it's a significant death rate relative to many parts of the world. Why is it so high here relative to many other countries?
So when you look at the epidemic itself in South Africa, and although it is convenient sampling, they've done some sero surveys, and they've done more systematic sero surveys recently, which basically gives us an idea in terms of what percentage of different populations have been infected with the virus. South Africa is way above what any of the high-income countries have actually documented as evidence of past infection. In fact, right now, recently, the South African Blood Services transfusion, as an example, indicated that anything between 40 to 60% of adults in South Africa might have been infected with the virus. More other surveys from the Cape Metro, even just after the first wave, already indicated that anything between 31 to 46% of people living with HIV or women that were attending antenatal clinics had been infected. So the virus in South Africa simply ran rampant in terms of its transmission. So even though there's another metric which is also useful, known as infection mortality rate, where you use your denominator as anyone that was infected with the virus and your numerator is the number of people that died, the South African infection mortality rate, even when using the excess mortality, is relatively modest, around about 0.4%, compared to 0.8 to 1.2% in high-income countries. But just in terms of absolute numbers, because of the large proportion that were infected, the absolute number of people that ended up dying, and as per capita, is much higher than has been experienced in many high-income countries. So essentially, it's been a story where we haven't been able to contain the transmission of the virus.
That then raises the question as to whether or not lockdowns work. Lockdowns fully enforced and properly administered perhaps work. Did the South African lockdowns work?
Yeah, it's very context specific. So a lockdown, as what happened in Wuhan in the initial stage of the pandemic, and lockdowns that took place in New Zealand, in Australia, and Iceland, those lockdowns were highly successful in containing the spread of the virus. And that's the reason why they're able to report 0 cases per day. Unfortunately, the South African circumstances never lended itself to a lockdown being able to contain the spread of the virus. Where we did benefit from the lockdown is one of buying time to allow our healthcare facilities to be better equipped to deal with the resurgence. And even then, there was a mixed success across the different provinces. The Western Cape, as an example, probably excelled in terms of making use of the time to adequately prepare themselves, as opposed to the Eastern Cape, which just simply was a disaster for all intents and purposes.
So, I mean, COVID then has been a failure of management, perhaps more than rather the spread of disease?
Yeah, I think it unmasks the fragility that exists, especially in our public healthcare systems, where at best of times, we sort of tethering at a risk of collapsing the service. And when there's any added pressure on that sort of service, it really crumbles. And unfortunately, that was experienced in many, many places in South Africa. And again, unfortunately, more so in a place such as the Eastern Cape.
And so with better management, and we look at healthcare systems across the globe, many healthcare systems at various points have been severely strained, but many of those healthcare systems have had considerably higher infection rates and considerably higher burdens placed on their healthcare services. This is not a place necessarily to talk about fixing the healthcare service, but it does come down to a question of management. I mean, if one province can excel and another can fail as dramatically as the Eastern Cape did, where people, the reports came out of people fighting over oxygen tanks and that sort of stuff in desperation. I mean, it does suggest that so much of our healthcare service is an issue of management rather than funding or any other issues.
Yeah, I mean, I think South Africa's health challenges is not one of funding. In fact, in the whole of Africa, South Africa spends more, even just using the amount of spend in the public sector. South Africa spends more per capita on health than any other African country. Yet, when you look at basic measures such as under 5 mortality rate or immunization coverage of children under the age of 5, we're actually lagging behind many other African countries, including neighboring African countries. So it speaks to an issue of efficiency within the healthcare system. It speaks to the issue of management. And all it takes is for pandemics such as the one that we experienced, especially in a country where we've got the ability to do the testing, for these sort of issues to unmask itself.
I want to talk about the impact of management then on vaccine rollouts, but perhaps we'll leave that one for later because we'll work up to vaccines and vaccine rollouts. Who in the world, to your mind, has done best in terms of, one, managing the initial impact of the crisis, and as we come out of the crisis in many parts of the world, who's doing well in terms of vaccinating populations?
Well, in terms of vaccinating populations, I think Israel has done the best. Over a very short period of time, they managed to have a very targeted approach, and they got large percentages of the population vaccinated, so much so that even the unvaccinated individuals ended up benefiting indirectly, because the successful targeting of high-risk individuals ended up bringing about an interruption in chain of transmissions of the virus. So even the children in Israel right now are being protected against being infected simply because the adults have been adequately vaccinated. So Israel is certainly a glowing example of a country that was able to implement and follow through its plans to get its population vaccinated as quickly as possible. But when it comes to the pandemic itself, the countries that have been most successful in terms of managing the pandemic happen to be island nations, such as New Zealand, such as Iceland. So it's easy for those countries to contain the spread of the virus if they've got available resources. But then the challenge is getting out of that sort of a lockdown of the country. And those countries are probably in much need of getting vaccines into their population to be able to return to a relatively normal lifestyle. But I think what we're also seeing now happening in the United States, even though they are beginning to experience somewhat of a resurgence, certainly shows the ability of countries to be able to scale up vaccination very rapidly. And hopefully in a month from now, the United States will be a very different picture as to where it stands when it comes to developing community immunity to bring about interruptions in transmission of the virus.
It's such an interesting point that you raised there, because one wonders what level of complacency creeps in as we see greater and greater numbers of people, and 3, 4, 5 million people a day getting vaccinated in the United States. Extraordinary vaccine rollouts. One wonders whether our people let their guard down too soon and then go maskless and start congregating more closely perhaps than they would have a month or two ago. One wonders just the risk of complacency in that almost window period of vaccination.
Yeah, absolutely. And I think that might be contributing to what's been experienced in the United States. In addition to which, it's only more recently that they've started to target younger age groups. So if you allow the virus to continue circulating amongst those younger age groups, who are particularly the ones that are less likely to be compliant with the wearing of face masks, more likely to be engaging in mass gatherings, you're going to have ongoing transmission of the virus, which is going to lend itself to these sort of spikes. In addition to which, we're obviously facing a scenario where the B117 variant, as an example, is also transmitting in the United States. And that is a virus that's much more transmissible. So I think there's a multiplicity of factors at play, which allows for this sort of resurgence to take place, even in the midst of you trying to increase your coverage with the COVID-19 vaccines.
Talk to me about B117, the so-called South African variant. There are lots of variants now, and those variants, I'm guessing, will mutate and grow as the vaccine. I don't know, do vaccines feel cornered? But vaccines do mutate. It's their natural survival instinct and their mechanism. Talk to me about the B117 and its transmissibility at the risk of new variants, just broadly speaking.
So I'll forgive you for mixing it up. The B117 is the UK variant.
Sorry.
The B1351 is the South African variant.
Now you know why they get given easy names, don't you?
But,
sorry. So 117 is the UK, and the one that they call ours is which one?
1351.
1351. Okay, got you.
Good. But I think a good starting point is the 117 variant for a number of reasons. And it shares a common mutation to the variant in South Africa, which is an important mutation in terms of making it more transmissible than ancestry virus. So it's about 53% more transmissible. In addition to which, it's also more virulent, which means that after a person has been infected, it's more likely that they end up in hospital or even die from COVID-19. So it's about 1.4 to 1.6-fold more virulent than ancestry virus. And the B117 shares a mutation with the B1351 variant that's responsible for that heightened transmissibility as well as virulence. Now, in addition to that, what the problem we face in South Africa is with the B1351 variant, there's additional mutations, which is making the virus relatively resistant to the antibody that has been induced by past infection, as well as the antibody that is induced by many of these first-generation COVID-19 vaccines that is targeted specifically to the spike protein. So what that results in is two major things. The first thing that we recognize is that past infection with ancestry virus, the immune responses that was induced didn't protect that well against reinfection and against developing mild to moderate infection due to the B1351 variant. So many people were sort of discussing the issue of getting to natural immunity by allowing people to get infected. But this is a classical example as to why that strategy would fail. Because when you allow large percentages of the population to get infected, they develop immunity, but the virus then starts to have selective mutations to try to evade that immunity. And that's exactly what happened in South Africa, where because of that selective pressure with the antibody that was induced by past infection, that probably forced the virus, in a sense, to start evolving and developing these mutations to become more adept in terms of evading that past immunity. So that's the first part. The second problem we face is that many of the vaccine constructs, including the Pfizer vaccine, AstraZeneca, Novavax, whichever vaccine you take, except for the inactivated vaccines, many of these constructs are specifically targeted to the spike protein where these mutations have taken place. So the antibody that's been induced by these vaccines is also not that potent against the B1351 variant. And there's going to be some drop-off in terms of how well those vaccines would be able to work in protecting at least against mild to moderate infection. But when it comes to severe disease, all of these vaccines very probably retain efficacy and effectiveness against severe disease.
Now, that's an important point because a huge controversy, and you've been very angry about this, has been South Africa's decision to sell on AstraZeneca vaccines, which arrived here, if memory serves, back in January and could all have been administered by now had we had our act together. But the South African government, in its wisdom, took advice and said, we're not going to use this because we want to vaccinate health workers first, and they need to be as protected as possible. The AstraZeneca vaccine doesn't protect against our variant. Therefore, let's rather pass this vaccine on to somebody else. We don't know at what price. And let's rather wait for something new. And I've used this analogy with you before. It's a bit like the person being swept down the Zambezi River towards Victoria Falls, going over the edge, being thrown a life belt or being thrown a rope, being told, no, I'm going to wait for a helicopter, thanks very much, as they get ever closer to the edge of the precipice. You've been very opposed to South Africa's decision on that front. I think it's quite a contentious point.
Yeah. So, Bruce, it's not me that's been opposed to that particular stance. It's the World Health Organization and the scientific advisory group of experts that informs the World Health Organization policy around us. And the consensus at the World Health Organization after the SAGE deliberations was that even in countries where the B.1.351 variant circulates, they should still continue using the AstraZeneca vaccine because it very likely will protect against severe disease. And there is animal model studies which basically corroborate that, where they find that despite a 9-fold reduction in terms of the potency of the antibody, when after vaccination, when these animals are actually challenged with the virus, they remain completely protected against developing infection of the lung, which causes the severe disease. So it's WHO that came in with that position. And I think for South Africa, it was a miscalculation. Unfortunately, the manner in which the South African study was analyzed, in fact, the data for all intents and purposes were probably overinterpreted and misinterpreted. The study that we did in South Africa was only able to test a single hypothesis, and that is whether vaccination had 60% or greater protection against mild to moderate infection. That was the only conclusion that we could actually come to. And the answer to that is that this vaccine does not have 60% or greater protection against mild to moderate infection, and particularly not due to the B.1.351 variant. Whether it's got lower efficacy against mild to moderate infection and what efficacy is against severe disease, including due to the B.1.351 variant, our findings are completely inconclusive with regard to that. But like I said, there's other data points which are useful in terms of trying to get some sort of an educated guess as to how this vaccine would still work against severe disease due to the B.1.351 variant. And that is the real basis on which WHO made its recommendation. The AstraZeneca vaccine right now happens to be the vaccine that is most in use in the whole of Africa. And unfortunately, that is not going to change, at least until the third or fourth quarter of this year, before other vaccines start becoming available through the COVAX facility. And this variant identified in South Africa now is the dominant variant in Zimbabwe, in Zambia, in Malawi, in Eswatini. In all of those places, more than 90% of the COVID-19 cases that are occurring is due to the B.1.351 variant.
Talk to me about further mutations. I mean, it's impossible to predict, but we know from the common flu virus that every year we have to get a jab to protect us against new mutations that have occurred over the last 12 months. In the same way as we're expecting this virus to continue mutating until enough of us are sufficiently protected for it to be kept at bay. It doesn't go away forever, I suspect.
I think the rate of mutation of SARS-CoV-2 has caught many scientists by surprise. They weren't predicting as rapid mutations as occurred, and especially not at key strategic components of the virus that we're targeting in terms of our vaccines. As you correctly point out, it's a moving game. Right now, there's another variant that's been identified in Tanzania, despite the limited testing and sequencing that's done in Tanzania, which in fact seems to be more problematic than even the variant identified in South Africa in terms of it having additional mutations that is probably going to confer greater resistance against the antibody that's induced by these vaccines. In San Francisco, they're finding in the United States, they are identifying variants that are similar to the variant in South Africa in terms of these shared mutations that are making the variants relatively resistant to these vaccine-induced antibodies. So I think it's going to be an ongoing story. And unfortunately, in countries that are sluggish with the rollout of the COVID-19 vaccines, those countries probably pose the greatest risk in terms of these sort of variants evolving over time. And that's the reason why World Health Organization keeps on arguing that until the global community is vaccinated, no one is safe, because these variants have been shown to be able to disperse fairly rapidly, including in countries where there is high levels of penetration of vaccine moving forward. Those countries don't remain immune against these variants being imported. So I think it's going to be an ongoing story. COVID-19, even after a successful rollout of the vaccine globally, is not going to be something that's going to disappear. It's going to be with us for the rest of our lifetimes. It's really about controlling the magnitude of severe disease and the number of people that die. As you know, in South Africa, each year, 10 to 11,000 people still die from seasonal influenza. And for me, that would be a good case scenario for COVID-19, where the number of people that die each year is not more than 10,000, as opposed to 150,000 in a 12-month calendar period, which is what we now experienced.
Do you envisage in the future us being, for those of us who do go and get flu jabs every year, that we will go and get our flu jab that'll have a COVID-19 element to it, an element of protection? Will it be a separate jab into the future? What does it look like?
Yeah, it depends on two major factors. The one is the duration of immunity that is induced by vaccines, and currently that's an unknown. The evidence that we've gotten from Pfizer indicates that 2 doses will confer at least protection for up to 6 months, but that's just because of the duration of observation for those studies. I'm fairly optimistic that you probably will at least get 2 to 3 years immunity induced by these vaccines. But the other big unknown is, as we've just been discussing, the issue of the evolution of the virus, whether there's ongoing mutations, becoming resistant to the current generation of vaccines. And if those mutations are significant, as occurs for seasonal influenza very often, then you're in a scenario where you probably require annual vaccination to target more specific variants. But that changes the ballgame completely. It's no longer about trying to get to herd immunity. And I think that's something that we need to start moving away from. If we face a scenario where you've got ongoing evolution of the virus, then it's really focused on preventing severe disease and death. So it's targeted vaccination of high-risk groups rather than trying to get to some sort of herd immunity through vaccination.
Explain to me why it is that we no longer worry about the Spanish flu. We no longer worry about the SARS outbreak that happened in Asia 10 or 12 years ago. We no longer worry about previous viruses, but we worry about this one in perpetuity. Why is it different?
Yeah, so I think SARS and MERS, those are two coronaviruses where the epidemics essentially burnt itself out because they were very less efficient in terms of transmission, and the modality of transmission probably differed. As we now appreciate with SARS-CoV-2, the main modality of transmission is airborne transmission. So it's a much more efficient way for this virus to disperse, and that's the reason why it's really dispersed throughout the world and is able to disperse very rapidly when you have, as an example, mass gatherings, which is not the case for MERS and SARS. For the Spanish flu, it's a different story in that there was basically evolution of immunity in the population, which eventually drove down the number of deaths that were occurring over time, over 2 to 3 year period. That's the period of time that the pandemic lasted. And that evolution of population immunity, coupled with ongoing mutations of the virus, assisted in terms of driving down the Spanish flu. Remember, H1N1 influenza virus still circulates today. It's one of the 3 major strains of influenza virus that circulates. So I think what we're facing with SARS-CoV-2 is a more typical type of respiratory pathogen, which is mainly airborne transmission and a high ability to continue surviving and transmitting in a very efficient manner.
Yeah, it's a horrible prospect. I mean, so many, and it's interesting. We asked our participants for questions earlier, and lots of questions came through, and a lot of them exhibit a real terror of COVID-19. And in some cases, and no judgment here, because I think we're all, I mean, present company accepted, of course, fairly ignorant of the technicalities of these viruses. But people are still very confused, I mean, about the transmissibility and the duration. We've been making viral vaccines for many years. Why is it taking so long to roll out this vaccine? I mean, this has got to have been historically the most extraordinary period of vaccinology in history. Rather than being a negative, it's a huge positive, isn't it?
No, absolutely. I mean, the science behind the development of a COVID-19 vaccine has been spectacular. Myself included, I never believed that anyone was going to be able to develop a vaccine within a space of less than 12 months, which is essentially what transpired. I mean, in the past, the quickest vaccine that was developed was a mumps vaccine, which took an average of about 4 years. And here, within 10 months of starting, we already have vaccines moving into the arms of people to protect them against COVID-19. So something that is completely unprecedented. And I think it bodes well in terms of future infectious diseases, where new technologies have now been used to develop vaccines in record time. And this technology has probably lend itself to develop vaccines against other infectious diseases, but also against other non-communicable diseases, including cancers, as an example. So it's really been fascinating what's occurred in a short period of time. In terms of the uncertainty when it comes to COVID-19, certainly 12 months ago, myself included, was extremely anxious about what would happen to me if I were infected with the virus. And I think that existed in many people's mind 12 months ago. But we've learned a lot. And we've also learned that the majority of individuals that are infected, if they're relatively healthy, if they're under the age of 60, 65, the chances of them ending up in hospital with severe disease is fairly low. It's really those individuals above the age of 65, the greatest risk factor for severe disease, that need to make sure that they take all precautions to avoid getting infected. And then individuals with obesity, hypertension, diabetes. So there's really a select group of individuals that account for close to 80 to 90% of hospitalizations, and that we still need to target and need to ensure that we get them protected as quickly as possible.
The risk there is we tell young people, you're okay. The trouble is, as we've seen in many cases, young people then go, well, masks off, let's go and have a good time. And you have nightclub events and big end of year matric parties, rages and everything else. The kids go and get infected and then take it home and give it to mum and dad or granny and grandpa. And that's been, I think, the big learning there as well. Just because you'll be okay doesn't mean everybody else around you will be.
Absolutely. Those secondary infections are really the major issue. And the way to overcome it is to basically make sure that we get the high-risk individuals vaccinated as quickly as possible. So we can have the virus continue circulating. People can get back to a relatively normal lifestyle, even if we end up just vaccinating 15 million of those high-risk individuals, because we're not trying to get rid of this virus any longer. It was never on our radar to be able to achieve that in South Africa. But what we're trying to do is reduce pressures on our healthcare facilities and protect people from dying. And the way to do that is to focus our attention on ensuring those high-risk individuals are vaccinated as quickly as possible. If we can get those 15 million people vaccinated in a space of the next 4 months, as an example, South Africa essentially would be able to get back to a relatively normal lifestyle, despite the virus still circulating in the country.
Talk to me about the efficiency of the state and the ability of the state to do it. You've been very critical of the state and its management of basic healthcare and the vulnerability of the healthcare system. The ability of the state to actually get those 15 million people vaccinated in the next 3 to 4 months, to my mind, is a very big ask. Do we have the capability? Do we have the political will? One looks at how slow the rollout has been so far. One has to question the ability of the state to get it done.
I don't think the state on its own will be able to get it done. I think it calls for a robust partnership between the public and the private sector. And in fact, much of the logistics and planning needs to be left to the private sector. And when I'm talking of the private sector, I'm not talking of medical aids. I'm talking of the full force of the private sector, people that are involved in logistic planning, people that are involved in all different aspects that are required to make this a success. If we got a robust partnership, we certainly probably would be able to vaccinate 100,000 people per day. Whether we would get to 300,000 people per day, that is extremely unlikely, unfortunately, in my mind. So South Africa has sort of set a new benchmark, trying to vaccinate, I think it's 29 million people by February of next year, as opposed to 40 million people by the end of this year. But even that 29 million people by February of next year would require us to vaccinate at least 85,000 people per day, each day, 24/7. And if we go with vaccines that require a 2-dose schedule, and I believe even a Johnson & Johnson vaccine eventually is going to end up as a 2-dose schedule, then you need to multiply that number to 160,000 people per day, 24/7. So those are large numbers, and it really requires planning. If we are serious about trying to roll out vaccine into phase 2 by the middle of May, what should be happening right now is that those individuals that would be eligible for vaccination, they should literally be given a time and a place to present themselves in a month from now. And that will show that we've actually got systems in place that will be able to achieve those sort of targets. Right now, I don't think we've still got clarity in terms of what the actual plan is. We've been told that there'll be up to about 2,000 facilities where vaccination will take place, and between 100 and 2,000 people will be vaccinated at each of those facilities. But those facilities need to be doing test runs right now to make sure that when we have those millions of doses of vaccine become available in the middle of May, that we can get it into the arms of people over shortest period of time as is possible.
So, Shabir, I mean, it's been so interesting recently how the world has got into a mad panic now about the J&J vaccine. It feels like Europe's response to AstraZeneca a couple of weeks ago.
Unfortunately, very much so. But part of it is really perhaps being overcautious in terms of when to stop and when to pause the program because of the huge spotlight under which the rollout of the COVID-19 vaccines is taking place. At the same time, I think we need to be cautious for this not to become habitual, because it could be hugely destructive in terms of what we're trying to achieve, and that is getting high-risk individuals vaccinated as quickly as possible.
Statistically, I mean, it's the risk of clots, and it was something like 6 women out of 6 million applications of the J&J vaccine with a very rare blood platelet disorder, and forgive me for not getting the facts exactly right on this. They were affected. 1 woman died, another was hospitalized, and 4 others had a negative reaction. Again, until you become a statistic, it doesn't really matter, but it is surely statistically insignificant risk.
Well, I wouldn't call it statistically insignificant. It's extremely rare. So it's in a magnitude of 1 in a million for J&J. For the AstraZeneca vaccine, it's in the region of about 5 in a million. But interestingly, there's a recent preprint which indicates, as an example, for the Pfizer vaccine, it's in the region of about 4 per million of the population. So this seems to be a type of a side effect that expands across all of the different vaccines. But relative to the occurrence of, as an example, the number of people that have died in South Africa from COVID-19, using the South African Medical Research Council data, even if you assume only 70% of the excess mortality is due to COVID-19, the number of people that have died in South Africa up to now is in the region of 1,800 per million of the population. So nowhere close to even 1 or 4 per million of the population. With COVID itself, after an individual has developed COVID, the risk of this sort of complication is in the region of about 40 per million. But obviously we know that COVID causes a whole lot of other complications other than these rare blood clots in the brain and in the blood supply to the gut.
So why then is there this huge level of caution amongst regulators around the globe for something that is considerably less significant than the very clear risks of infection?
So I think the reasons differ. In South Africa, the reason for pausing the use of the vaccine probably had more to do with the fact that this vaccine was currently being used as part of a clinical trial rather than and under the conditions of a clinical trial, there is a responsibility on the investigators to keep the participants and volunteers abreast of the latest information. So there's some paperwork that needs to take place that needs to be approved by SAPRA and the ethics committee before they can continue enrolling individuals into a clinical trial. But once you're rolling out the vaccine, it's a very different sort of a calculus. The calculus then is one of a risk benefit. And clearly the benefit is the equation is overwhelming in favor of benefit of continuing the program. But the United States, as an example, is a country that is in a sense is spoiled for choice in terms of having access to other vaccines. So when you've got that sort of luxury, it might make sense to pause the use of a particular vaccine when you know that you can actually fill that gap with another vaccine. That unfortunately is not going to be the reality in South Africa, where we're probably going to have limited supply of either the Pfizer or the Johnson & Johnson vaccine at any point in time. So I think the learning lesson from this, and I'm glad that it happened at this early stage of the rollout of the program, is that we cannot afford for there to be interruptions in terms of the rollout of the program when we face with these rare occurrences. And there needs to be a serious reflection in terms of the risk-benefit ratio before making these sort of decisions moving forward.
I remember once buying a coffee from McDonald's, and on the lid it says, "Caution, contents hot." And I thought to myself, it's a ludicrous warning. But there are some people who are going to think it's a Coca-Cola and drink it down and burn themselves and then sue McDonald's. Do the vaccine providers simply need to put a health warning on saying, if you have one of the following conditions or a range of conditions or fear that you may have a range of conditions, perhaps get medical advice before taking this vaccine, and then we can go on applying the vaccine?
So unfortunately, in this particular for this particular side effect, there isn't any compelling evidence to indicate that there's an individual category of individuals that are at risk of developing this sort of clots and what we call a low platelet count. So what the manufacturers will be doing is updating the patient information leaflet to indicate that this is a potential risk. But right now, we don't have data to indicate which category of individuals might be at greater risk. Initially, the thinking was individuals, especially females under the age of 50, but more recent analysis in the United Kingdom, at least for AstraZeneca vaccine, indicates that age might not be that much of a factor, neither is gender. So unfortunately, it's difficult to predict exactly who it might be that would be at risk of developing these sort of complications.
And I suppose for a delay of a week or two or three, and hopefully no longer, in a social media world where so many opinions are driven by what we see and read on these things, any doubt that can be easily dispelled, and this is what the vaccine producers are trying to do, is best dispelled early so that there is a scientific response to any misinformation that comes out, because the world is awash with misinformation.
Exactly, and I think all credit to SAPRA in South Africa for having been really expeditious in terms of its review of these events and actually giving the go-ahead. And hopefully the ethics committee will also now provide a go-ahead for continued enrollment into this effectiveness study of the J&J vaccine. But again, important lessons to be learned moving forward as we roll out our other vaccines. And we also need to understand that it's important that we don't go it alone. So the World Health Organization has got a specific working group that deals with this almost on a daily basis. And when the need arises, they would meet and come up with recommendations. And it's important for us, rather than to try to go it alone, to take our lead from this recommendation from the World Health Organization, which will assist us in not disrupting our program unnecessarily.
Why could, question from our audience, why could GPs and pharmacies not administer the vaccine? Is that a distribution and security issue, or what is it?
Not at all. They absolutely need to be central to the plan. In fact, I think GPs and pharmacists have got a much greater outreach in terms of accessibility to populations, even in rural areas, than the public healthcare facilities. So when we talk of this private-public partnership, it includes GPs, pharmacists, it includes different elements, including the Pick and Pays and the Checkers and the Coca-Colas, because they understand what it is when it comes to logistics of deployment. And we need to be leveraging on those sort of expertise rather than trying to reinvent the wheel.
There was another fabulous question. Can one decide or choose which vaccination to take? I would prefer the Pfizer one. Because I object to the use of stem cells, for example. I do like it. Our people at the height of the pandemic are very picky. I'd like the one in the red box, please, not the blue box, or whatever the case might be. Is it going to come down to, you're next in the queue, this is the vaccine, if you don't want to take it, you don't have to, but this is what we have available, your choice?
Yeah, I mean, I've got my own preferences, which one I would prefer. But unfortunately, that is not going to be the reality for South Africa. We're not going to be spoiled for choice, at least not during the course of 2021, as to which vaccines are going to be available to us. Right now, it's only two vaccines, and that is a Johnson & Johnson vaccine and a Pfizer vaccine. I think there's some talk about the reconsideration as to whether the Novavax vaccine would also be made available. And that is one of the vaccines that's being offered to South Africa through the COVAX facility. At most, it's probably going to be those three vaccines, at least in the last quarter of this year. So if you're wanting to be vaccinated soon, it's really taking what is offered to you. And again, I think people, especially those at high risk of developing severe disease, if they're wanting to be selective in terms of which vaccine they choose, it's really analogous to that image that you presented, where people are about to fall off the cliff and waiting for their vaccine of choice to become available to them, which would be ill-advised.
When it comes to the vaccines that are available, I was speaking to a pharmacist the other day saying he's going to wait until the end of the year when there'll be a nasal vaccine rather than an injected vaccine. And he gave me a long pharmacological answer to a follow-up question I had, which I didn't understand. Is it worth waiting for the evolution of vaccines to catch up with variants, or are you better off getting your vaccine as quickly as possible and possibly topping up later?
Absolutely. You're better off getting a vaccine now and topping up later. And this sort of intranasal vaccines, as well as sublingual and oral vaccines, they might well become a reality. But it's unlikely they're going to become a reality before 2022, because they need to go through a fair amount of testing still. And those vaccines might well lend itself to better immune responses than a vaccine that you get as an injection. But again, I would much rather be taking a vaccine now and topping up with another generation of vaccine if those do become available in the future.
Side effects of vaccines. There's some concern around that by our questions. I've got a doctor friend who's, 2 or 3 days afterwards, there was a bit of tenderness around the point where he was injected, but I've had that with the flu vaccine. Besides that, no side effects whatsoever. I wonder if it's an individual thing.
So unfortunately, with the vector-based vaccines, the Johnson & Johnson, as well as the AstraZeneca vaccine, as well as the messenger RNA vaccines, what we call the reactogenicity, those local reactions, as well as some systemic reactions such as headaches, fever, it is somewhat higher than is the case for, as an example, influenza vaccines. And especially for the messenger RNA vaccines, after you get a second dose. For the vector-based vaccines, it's more after the first dose. So it is higher percentage-wise in terms of the people that will have these side effects compared to what one will experience with influenza vaccine. But importantly, these are self-limiting side effects. Occasionally, it might be making people feel really miserable for at least 24 to 48 hours. But in a sense, that is indicative of the body's immune system mounting a response against the vaccine. And that's the reason you're actually developing those side effects. It's showing that your immune system is actually mounting a reaction, which is exactly what we're wanting to do with these vaccines.
If I've got underlying respiratory comorbidities, there's some concern that already I'm weak and vulnerable. If I have the vaccine, it could make me sick. Surely the purpose of the vaccine is to prevent yourself from getting sick. So no concern around existing sort of health conditions. Surely those are the people who should be getting that most quickly.
Absolutely. The risk-benefit ratio is clearly in favor of benefit by being vaccinated if you've got any sort of comorbidities. And yes, you are going to experience some sort of side effects. Interestingly, for a vector-based vaccines, Johnson & Johnson and the AstraZeneca vaccine, the elderly have less side effects than the younger age group. But again, that comes at a cost of a slightly dampened immune response. But at the end of the day, the risk-benefit ratio is clearly in favor of vaccination in individuals that have comorbidities as well as individuals without comorbidities.
There was some concern around clotting. I think it was AstraZeneca and clotting, and suddenly half of Europe stopped vaccinating, and there was a big study, and I think 32 people, or a relatively small handful of people, had developed clotting, which may or may not have been related to the vaccines. Any concerns there?
So the rate of clotting was in a region of about 2 per million of the population amongst those that were vaccinated, which wasn't very different from the general population. In fact, slightly lower than in the general population in the United Kingdom. But over the past few days, there is another syndrome that has been identified, which is known as central venous thrombosis, which is clotting of the veins in the brain. And there is some concern that females, and especially people under the age of 50, might be disproportionately affected by this particular syndrome, which includes what is known as thrombocytopenia, where there's this platelets in the blood which assist you in terms of clotting, those platelet counts going down. So this is something that is currently under investigation. That being said, the risk-benefit ratio still is in favor of vaccination. But right now, as we speak, in fact, the MHRA in the United Kingdom and other regulatory authorities in the EU are currently looking at the data, and probably today or tomorrow, there might well be some pronouncement as to whether they believe the risk-benefit ratio has changed, and particularly in people under the age of 50.
If I've had COVID-19, do I need a vaccine? I would think with the variants you would.
Interestingly, you're probably less in need of a vaccine, especially with these first-generation vaccines if you've been infected with the virus, and more so if you've been recently infected with the B.1.351 variant. Because evidence shows that the immune responses that's been induced by infection with a B.1.351 variant, in fact, is giving you cross-protection against ancestry virus, which was not the case in reverse. So you're probably still wanting to get vaccinated if you've been infected, but you're probably less in need of a vaccine. In addition to which, if you have been infected, even for vaccines that usually require 2 doses, you probably then only require a single dose, because your past infection is a good priming event, and you actually get a remarkable booster response just after a single dose, including of the Pfizer vaccine as an example. In fact, people that were previously infected, after getting a single dose, they end up with a much better immune response than people that weren't previously infected who have received 2 doses of the Pfizer vaccine, as well as the AstraZeneca vaccine for that matter.
Good, thank you. Will the vaccine work for somebody with an autoimmune disorder?
There's no indication that people with autoimmune disorders would be negatively impacted with the vaccine. So the recommendation is for those individuals, many of whom are on immunosuppressive therapy, to be vaccinated. Again, clearly, in terms of the risk-benefit ratio, clearly in favor of being vaccinated.
What if there's a risk that you may be infected? You went for lunch with somebody last week and you've had a notification via the app that you've been exposed to somebody with COVID, or your friend phones you and says, "Terribly sorry. I know we shared a bottle of wine without glasses yesterday. We drank from the bottle and it was very festive. I've just been diagnosed with COVID. Chances are you might be too, but you've got your vaccine scheduled for tomorrow." Do you go for the vaccine, or do you make sure that you're not infected before the vaccine? Is there a risk there, heightened risk?
Yeah, well, it's going to take at least 14 to 21 days for the vaccine to kick in to provide you any protection. So I would still go for the vaccine. Remember, it also depends on the closeness of the interaction. Not everyone that is exposed is going to get infected. In fact, within a household, it's only about 1/3 of the household that will actually get infected.
Isn't that extraordinary, though? I mean, we mustn't play down the importance of washing of hands and masks and everything else. But if this thing is so transmissible, even within households, we're seeing, I mean, I've spotted it anecdotally, you've got the scientific evidence, that not everybody necessarily gets sick.
It's really a function of close, poorly ventilated indoor spaces that determines risk, and a closeness, the duration of contact. So as an example, in my household, with 2 teenage children that I never see, the chances of them getting infected from me is quite low, and vice versa, fortunately. But certainly if you've got a high density in the household, many people in small, crowded, poorly ventilated spaces, then that percentage probably increases. But on average, it's probably a 1 in 3 chance of being infected in a household. And more so, and even lower, if people that are infected end up going into self-isolation or have the means to go into self-isolation within the household.
So therefore, talk to me about the fact that possibly 40 to 60% of South Africa's population has been infected. Discovery's Adrian Gore puts it slightly higher than that. We're going towards colder winter months. What happens in colder winter months is we tend to confine ourselves more. We close more windows, close the curtains if we've got them, or we go into tight confined spaces. Transmissibility then rises. It was the big fear through winter last year, and it's going to be a big fear again this year.
Absolutely. And I think that's the reason many people predict that as we're going towards the end of May, June, that we're going to see another resurgence, exactly for the reasons you mentioned, where people are more likely to gather indoors and the windows are going to be shut, poor ventilation, and people are going to be infected and transmit the virus. And as we discussed before, people are still getting infected with a B1351 variant, despite them having had previous infection with ancestry virus, because that past infection with ancestry virus is not protecting against mild infection due to the B1351 variant in any meaningful quantity. But I think what might differ the next time around with the third wave is we're probably likely to experience lower number of cases that end up in hospital and lower number of people dying from COVID-19. Because there's 50 to 60% of the population that have probably been infected, they have developed levels of immunity that at least protects them against severe disease. So yes, we're likely to experience a resurgence, but all indications, unless something dramatic happens with further mutations of the virus, if the virus remains relatively stable, the next resurgence probably will end up having much lower rates in terms of hospitalization as well as death, which is really the most important metric to focus on.
It just comes down to management of the crisis and the illness. So I asked you earlier who's done well. Who's done badly? I mean, when you look at South Africa's response, you look at the success of the response or the failure of the response, where do we sit globally, in your opinion?
In my opinion, I think we probably, like I said, we amongst the top 10, 15 countries with the highest mortality rate. But whether that was avoidable in our own context, I don't think it was avoidable. I think it was always naive for us to believe that we were going to contain the spread of the virus given our socioeconomic conditions. So I think generally we have performed reasonably well. So if I were to score it 1 out of 10, if that's what you're asking, I'd probably give it a 6 to a 7 out of 10. I think where we've fallen short dramatically is when it comes to the rollout of COVID-19 vaccines. I mean, that has been just an absolute disaster. We're one of few countries that is yet to start a COVID-19 vaccination program. What's currently happening in healthcare workers is not part of a general COVID-19 vaccine rollout program. It's been done as part of a implementation study. So we're really lagging behind when it comes to that. And I think there were a number of miscalculations right from the outset in terms of a high dependency on the COVAX facility as the main source of vaccine procurement, knowing full well that we weren't going to get more than 10 to 20% of vaccine to cover in terms of the amount of vaccine that was going to be made available to cover our population. So we did come short in terms of delaying in those sort of bilaterals that would have put us into a more favorable position to get vaccine as early as possible.
The optimist in me looks at the rapidity of the rollouts in the United States, for example, in the United Kingdom, parts of Europe being very, very good and efficient. The factories that are producing these vaccines are still gearing up to produce. So once those populations are immunized, it's logical to me that we then sort of see a greater flood of vaccines towards the rest of the world. I mean, it's a logical conclusion or not?
Absolutely. By the third quarter of this year, come July, August, we probably will be spoiled for choice in terms of which vaccines are made available to us, because by then, the US, UK, many of the Northern Hemisphere high-income countries will already have got at least 60 to 70% of the adult population vaccinated. And that is sort of almost a ceiling in a sense, in terms of the percentage of the population that will be willing to be vaccinated in those areas. So then all of the vaccine that has already been procured by those countries in terms of bilaterals that will become available to them, I think those countries will either donate those excess doses of vaccine to the COVAX facility or alternatively allow companies to basically sell it off to other bidders. So I think come around about August, September, we're going to have many more options available to us, and we'll be able to get even larger quantities than what government has already secured.
I mean, is there any argument for unilateral declarations of independence at some point when these manufacturers are no longer just selling to governments and will sell to companies? For example, if you're an Anglo-American or you're a Sibanye-Stillwater or you are a Discovery Health or a MedScheme or whomever, to actually say, you know what, we've got 100,000 or 3 million members or whatever the case might be. It's in our best interests to vaccinate our populations, and we are going to do it because the rollout isn't working effectively enough? Or does everybody need to play nice on this and just wait their turn, which is quite a big ask in a country where we know we haven't covered ourselves in vaccine glory?
We were speaking about a public-private partnership, and I think we would be shortchanging ourselves if we don't allow the private sector to actually engage in those sort of initiatives. What we need is as much vaccine into the country as quickly as possible. I think the challenge that we face in terms of those private sector is the issue of liability related to side effects of the vaccine. And many of the companies are insisting that governments actually put up collateral in terms of taking on the responsibility for any sort of liability, and how the private sector would be able to navigate that is going to be a major issue. So there is a different dimension to it, which hasn't been sorted out as yet, which might sort of impact on the success of the private sector in terms of engaging those bilaterals with companies. But I think government needs to allow the private sector to see whether it can be successful in terms of procuring more vaccines, given that they themselves have already now procured enough vaccine for close on to 40 million based on the numbers they've released.
And last couple of questions. When can I travel to the UK? When can my relatives in the UK travel to visit me? When do you think that'll be the case?
You know, it depends how the world continues to view the B1351 variant. And it might well be that even if you're vaccinated and you're coming from South Africa and there's still a significant amount of transmission of the B1351 variant in South Africa, and we know these vaccines might not protect you against mild infection, that those sort of travel restrictions are going to be kept in place. So it largely depends on the trajectory of COVID-19 in South Africa. If we go into a phase where there's very low transmission of the virus and people are vaccinated, I think countries will be willing to open their borders. So it really depends on how this virus continues behaving in the country.
Okay, personal question. I got really agitated last year. I had a fantastic beach holiday prepared for December last year. And then we went into the second wave, and it was in the Eastern Cape, and we were a bit concerned about that. And then the president closed the beaches, and we cancelled our holiday. It just didn't seem worthwhile to go and sit in a house and look at the sea rather than swim in it. Can we safely book a domestic holiday, do you think, for December this year? From what you've said, it would appear that you'd be confident in doing it, would you?
Well, I did my holiday last in the Western Cape as well as in KZN, and I got back the night before the president decided to close the beaches again. So I was relatively fortunate in my timing. The bottom line is that there's absolutely zero reason for us to be shutting down beaches. In fact, it's one of the safest activities. Yes, I can understand placing restrictions on New Year's Day on the 25th and the 26th of December, but beyond that, to shut down the beaches makes absolute no sense. In fact, it's one of the safest activities that you can engage in, given the amount of breeze on the beach and the spacing between people. What effectively happened when South Africa shut down the beaches during the vacation period is I noticed people ending up in the restaurants and getting crowded in these indoor facilities, which probably assisted the transmission of the virus. So I think it's safe to be planning for a beach holiday, personally. But what government decides eventually, I can't second guess that any longer.
Yeah. Look, it's been. I think we've learned an awful amount, and hopefully we don't get these too many terrible variants. But I mean, it is a massively unpredictable and moving target, isn't it? And that's the great problem with pandemics. I mean, this is something new for everybody.
Yeah, Bruce, that's true. But again, I'm beginning to be more optimistic based on experience in a Cape Metro. And I think that's an important learning lesson there. That Khayelitsha, as an example, in Klipfontein, those were two sub-districts that were most heavily affected during the course of the first wave. But when you look at the second wave in the Cape Metro, those two areas, and particularly Khayelitsha, had the lowest case fatality rate, basically indicating that even though that past infection might not protect you against reinfection, it's at least protecting against severe disease. And I think if we're saying that 50-60% of South Africans have now been infected, yes, there might be ongoing transmission of the virus, but again, those people are likely to be protected against severe disease and death, which is, again, the most important metric that we need to keep at the back of our mind in terms of planning how we continue responding to the pandemic.
Professor Shabir Madhi, thank you very much indeed. Janine, back to you.
Thanks, Bruce.
Thank you, Bruce. Thank you, Professor Madhi. How insightful. A staggering statistic. SA is in the top 10 to 15 countries with the highest COVID-19 mortality rate in the world, which indicates the high rate of transmission. My takeaway today is that South Africa needs to bolster its efforts to get high-risk individuals vaccinated as soon as possible if we want to see fewer deaths. On the bright side, Prof. Madhi rates South Africa's management of the pandemic a 6 to 7 out of 10 under the circumstances. He advocates that the high-risk individuals get vaccinated, as current studies show that the risk-benefit ratio is in favor of vaccinations. The world has also made huge strides in getting a vaccine ready in such a short period of time, which is a positive for future pandemics. He also thinks that a beach holiday this December is on the cards for all of us. COVID-19 vaccinations still pose lots of uncertainty. We still do not have certainty around how long does the vaccines last and how often we should take the vaccine. But I am sure that healthcare professionals and scientists are relentlessly working on solutions. And Prof. Madhi's view on what is going to be normal sounds like getting used to uncertainty. Therefore, when it comes to finances during these times, a skilled and trusted financial advisor can be invaluable. They can provide objective insights and help you consider alternative scenarios so you can make informed decisions on your wealth and insurance portfolios. If you don't have a financial advisor, then please get in touch with us. If you do, I encourage you to get in touch with them. While we welcome your feedback, so please do communicate with us and be sure to register for the next installment of our Think Big series. Premier Alan Windey will be talking to us about the future of the Western Cape. Thanks and goodbye until next time.